Hello, everyone. Welcome. Welcome to this second session on the webinar series, Chronic Disease Management. Good evening, everyone. My name is Julio Robledo. I am the Quality Improvement and Reform Project Officer here at the Brisbane RPHN, and we're very happy to bring you this session. I would like to start tonight's session with an acknowledgement to country. We acknowledge the traditional custodians across the land in which we are meeting today. We acknowledge the waterways, the land, the sky. We acknowledge their ancestors and elders and recognize those who continue to protect and promote Aboriginal and Torres Strait Islander cultures. We acknowledge the past and stand together for our future. So a little bit of housekeeping for tonight. Everyone is by default muted and by default with the camera off. If during the session there's questions, please pop them in the Q&A box. We're going to be actively looking into this function to see if there's any questions. At the end of the session, we're going to have a little bit of time to go over those questions. If there is a very important question during one part of the topics, we'll flag them and we'll be answering them through the session as well. We're going to have a survey at the end of the webinar. It's going to pop up automatically in your browser. You have to click on allow, and then it's going to pop up the survey. So please help us answering the survey. This survey helps us gather information of what are your needs and provides feedback on how the session went. And in overall, it helps us improve the quality of the sessions that we bring to you. And it also helps us know what is it that you're looking for to upskill. This session is going to be recorded. We usually take a couple of times to send the recording. There's also going to be some resources that are going to be shared. So please wait a little bit, be patient. It will get to you in the next couple of weeks. And without further ado, I would like to introduce you to the speaker tonight, Jen Calderos. Welcome tonight. You've been a wonderful speaker in the past. I think you need no introduction. So please take it away.
Thanks, Julio. So thanks so much for that introduction. For those that were on last week's session, we did a bit of a little Medicare update. You will have access to the previous week's recordings and slides in that online portal and resources that will be made available to you. But tonight we're going to jump in and have a look at how to actually perform a care plan. So the hope is by the end of this session, you'll be able to identify eligible patients for the care plan and reviews and apply that learning to actually perform a care plan. I'll be using best practice tonight, and I'll talk about if you're using other software. The whole process is exactly the same, I guess. It's a little bit different when you get to the template side of things. So we'll have a look at the text shortcuts before we kick into the actual care plan. And I'm a really big fan of the progress shortcut, so I'll show you how to do those. In the background, we'll talk a little bit about the care plan and reviews of what's needed in those. I've got some additional Medicare information if we need it. We did speak about the upcoming changes that will be coming into place in July next year. So they've been postponed. So as that information changes, so the actual process for putting a plan now and when those changes happen will most likely be the same. It will be the item numbers and a few little changes around the descriptions, and hopefully a little bit less paperwork is what we're all hoping for. So I'll do that care plan demonstration, and we'll talk about home medicines review as well. With the home medicines review, it's something I prefer to do if the patient's actually eligible to generate that referral during a care plan appointment. So it makes sense that we talk about that tonight. So it'll be one of those steps that we actually will go through as part of that care plan process as well. All right, so text shortcuts. These are a really great prompt for all of those chronic disease management activities. So we have them set up for all of our care plans reviews and the 11 different types of health assessments that are available. So if you've got kind of big teams working on chronic disease management, so multiple nurses and GPs, then it's a really good idea to get your staff together and maybe put a process around what information you want to gather into your care plans or health checks as an example. I can't remember anything anymore, so I really need those prompts to help me write really good progress notes in case of audits and consistency and things like that. So it also increases the efficiency, less time to actually get that documentation done, and we're actually making sure that we have everything we need to actually complete certain item numbers as well. So I've got the example there of that 10997, so that follow-up nurse item number. If we looked up that Medicare description like we did in that session last week, those dot points are straight from that explanatory note of the 10997. So I'll show you into best practice just so we can have a look at that. So you should be able to see my best practice screen. Down in the bottom section, you've got autofills. So most likely, all your clinics will actually have something set up in here. Some might be available to you, some might not. So for those big activities like anything to do with care plans, chronic disease management, health assessments, a lot of the follow-up numbers, even things like ECGs or some of the screening tools that we might use, procedures, immunizations, the list is endless. So if you haven't set one of these up before, you just go into your test patient, click on the autofill down the bottom, and then you should just be able to add. If you can't see that feature when you open up, you might not have the permissions, but it's most likely everyone will have the permission to be able to do that. The copy and paste, if you're opening up from like a Word document, does it a lot nicer. You'll have the PDF. You'll actually have the Word version in the online portal. We're actually sharing our text shortcuts with you guys as one of the resources. So you'll actually have these. So pretend this is the Word document version. You'll just kind of copy that text across. And you can just paste it in. So you can see it just folds across the other lines if you're doing it from a PDF. But if you did it straight from a Word document, the lines stay exactly the same. You need to give it a code. And the reason I use a hashtag or some other symbol in front was because if I just wrote GPMP as that text shortcut, then all you need to do is write GPMP and space or enter, and that shortcut's going to pop up. So we don't want that coming into everyone's progress notes if they're just mentioning like a simple word. So use a symbol. It doesn't have to be the hashtag, but it's good to just have something front of them so we don't have it just jumping into the text randomly. So there are our text shortcuts. So have a look at what you've got. It's a really great time to go back and see what you've actually got set up in those. Do they need to be updated? So things change with item numbers all the time. For those that weren't on last week's session with the update, there has been some of the changes around the health assessments. So you might want to just go back and have a look at your text shortcuts if you had some of those for your health assessments. And when I jump in to do the care plan in a second, then you'll see the one that we've got for the care plan. So I'll do that in one sec. I'm just going to come back to our main slides. So in the other resources that you'll get access to will be our CDM manual. It's been endorsed by APNA. So you actually get 4 CPD points for the manual and completing that as a reading task, which is really good. The whole idea of that manual is a step-by-step. So as we spoke about last week in the processes, it's not just one person usually completing the care plan. So there's a lot of touch points from a practice team and including the patient as well. So we've broken ours up into obviously the eligibility. So what patients are actually eligible for that particular activity. And then it goes through a step by step. So what happens before the appointment? And we spoke about some of the reception tasks that they may be doing. And I'll go through those as we go through the process. The nurse or Aboriginal health worker, or if it's the GP completing the whole plan, what steps do they need to do to put that information together? And then the GP steps. And then the process usually ends with reception and billing and that process that we spoke about last week, which was booking that next appointment. So I'm going to jump into best practice to work through this now. There are some additional slides and information just so you've got it, but you'll actually have access to those steps and the digital versions of this manual and resource in that portal you'll have access to. Okay, so I'm going to jump in. So I like to, from a nurse point of view, if I'm putting that care plan together, so if I'm that CDM nurse working, I like to break that appointment up into three sections. So before I call the patient in from the waiting room, I do a very technical step, which is before I see the patient. I'll see the patient once I've got everything ready that I need, and I'll have them in the room for maybe 15, 20 minutes. So the most popular question I always get asked is, how long do we need to have that care plan appointment for? Now, my preference is around that 40, 45 minutes, and it's mainly because I don't want to do paperwork at the end of the day. So I set my appointment up in a way that I get everything done in that 45 minutes. But it just depends on your process and the expectations of whether, the nurse is doing all the documentation, if it's just the plan, or we're looking at some of the other prevention and early detection activities. So I do that 10-minute prep before the patient comes in the room. So from when they arrive in the waiting room to when I call them in the room, I do the care plan and activity with them, and then I actually get them to go back out to the waiting room, and I'll finish typing up the documentation and finishing everything off. So that's my process. You don't have to do the process like we've got documented in the manual either. Every clinic has their own way of doing it. So have a look at the process that we've got, have a look at the text shortcuts, and you may just adapt what we have set up there. Okay, so the first thing that I'm going to do is just show you that chapter so you can see it. So the first page of each chapter in our manual has the eligibility requirements from Medicare. And then we start with reception. So my preference is to not to do any of the big activities until they've actually had the PROTA check done in the background. And so a lot of clinics do this as a step. I prefer it to be an admin task, and we usually get that done the afternoon before. So the item numbers that you'll get them to check, etc., is going to be down to each clinic. But these are the before steps that we like admin to do as a role. So if I look at that from their point of view, they'll be doing things like documenting that eligibility, and I'll show you where we would do that in the patient file. And then on arrival, they'll be updating the patient details. Okay, so we would normally get admin to be documenting in that appointment note section. And that way it's visible to me. So even if I was working in the treatment room today, I prefer the eligibility checks to be done for all patients, because I'm more likely to see a patient coming through, and if I know that they're actually, eligible for a health check or a care plan, when I see them, I can get them to book back in. And so it's not to complete that activity on the day, but it's to recognize that we can actually get them back for one of those bigger activities, as we did in the case studies last week. Okay, so before I call the patient in from the waiting room, so that's reception steps done. Before I call them in, I'm going to go through this little process, which I've called before you see the patient. So the reason I kind of started this as a process was I didn't want to spend my time just typing while the patient's trying to talk to me. I wanted to be as engaged as I could with them during those appointments. So I found it had a really big impact on the patient engagement. And so what I did was I'd put everything I need to, as much as I could, into my progress notes ready. So I'm going to pop that shortcut in. So I'm just going to double click, and you can see my shortcuts popped in there. Now, if I fill out what I can in here, it does two things for me. One, it's less typing for when the patient's with me in the room. But the second thing is I can actually see where the gaps are. So if they haven't had bloods done, or if I can't see, a specialist letter that's come back, or if there's something missing, it's really easy to spot it. And then I can put some more, a better plan around that appointment when the patient comes through. So it's a little bit more strategic, so the appointment workflow works really well, because they're usually asking questions like, how was my bloods? And, I just came back from holidays, and, there's a lot of conversation happening, and we've got to get the information out at that same time. So it just gives us a little bit more direction. So I'll also have a quick look at the billing. So if you're in best practice, you're just going to jump up into the billing history. If you were using medical director, sorry, one popped over there. So I'm just going to have a quick look in the billing history just to make sure that they're eligible for that particular item number. And yeah, if it was medical director, you'd be using Praxsoft and having a look in the billing information through Praxsoft. So all I'm going to do is have a quick look at what chronic conditions this patient has. So I'm going to have a quick look in the past history and just start putting that information in. So asthma and diabetes. Everyone's going to see how great my typing is and why I like to do this before the patient's in the room. The last care plan. So I like to put the date of that last plan. So it might be the 20th of October 23. Now, this is my little prompt. And as I said, you don't have to do the text shortcut like we have. I've done this in a way so it actually matches the steps in the manual. So even though I don't use the manual to do a care plan anymore because I've been doing it for years and years, I still use the text shortcut because I still can't remember the 10 or so dot points. So this one around the consent is and explaining this to the patient is just my reminder when they come in. Because some patients will go, oh, I'm not quite sure why I'm here. They told me to book in for the nurse. I need to, get a care plan or something. So it's just to make sure that they're understanding what activity is actually getting completed in the clinic today. I'm going to go through these next steps as we go now, just so you can see what happens in there. That was the bit around the consent. So I'm going to do this patient details section next. So we'll do that all together. This is a really important section. A lot of clinics that I work with, sometimes this is a very empty section in the file. There's usually a big push when we go around for accreditation and we're trying to get everything up to date. From a chronic disease point of view, especially when we're looking at that prevention and early detection, the family history, social history, medical, surgical, that's really, really important info. So I've got it as my prompt here. In that little table you saw, I've got example formats of how to lay it out as well. So you don't have to do it like this. That's just some examples if you weren't quite sure what to put in those sections. So again, it's just some ideas if you're not quite sure how to get that organised for the team. So let me just jump in here. And I just work through that whole section one at a time. So you can see the family history is actually really easy to add in BP. So they've got those really common conditions as little tick boxes. The parent says the mother or father still alive, if they've passed away, a rough age, or if unknown, as close as we can get, and then the actual cause of death on there as well. I add a little extra bit down here. I like to lay out the siblings in that format. So you can see I've got one brother, one sister, and one brother died, one sister still alive, and the conditions next to it. You don't have to do it like that. I just prefer the way it looks when we actually print the plan or any health summaries. It just lays out that information of the family history a little bit better. So it's personal preference for those. In the social history, there's a couple of really good little fields, especially if we've got those really complex patients where there's multiple care providers involved. So you can see we've got the boxes there for the advanced health directives, power of attorney, any on-screen comments. So I've got hello written in mine. Clinics will usually put lots of different information here. It's probably good to decide what qualifies to go in this little section. And just be aware that sometimes the patients can see the screen that you're looking at as well. So yeah, I think just be careful of what you're documenting in that section and the visibility of that. Accommodations, our own home, relative, and who they're living with, etc. Any carer details. So that's really important to update that information as well. And then I add a little bit of extra social information here. So especially if we're helping to set up support services and this plan is actually going out to external providers, it's really helpful to have as much information as we can. So, who they're living with, if they've got kids as an example, are they local, interstate, overseas? And we've started adding in with a lot of patients being, whether it's NDIS or, they're receiving, home care packages and, other funding or programs or services. It's really a great place to document it. If it was medical director, I'd put it in that social section as well. So yeah, it's just really good to decide as a team where you want that information displayed, but I think it makes sense to kind of jump it in under that social section. Occupation. Now, I always say when we do training that this was not something I did very well. I always just used to tick the retired box, and that was kind of it for a lot of the over 75s and things. But when we started doing a lot of screening, especially for things like COPD, that past history, past occupation history becomes very important. So I usually spend a little bit of time updating that section as well, and then updating the alcohol and smoking. So um, a question or a topic to raise with the clinical team is where are you going to be recording additional information like other drugs and substances? So a lot of clinics will usually document it in that little comment box under the tobacco. Some people will record it in kind of the past history sections and things like that. So it's something to just have a conversation about with the clinical team, so then everyone's on the same page and documenting it like consistently if we need to record that anywhere. So that's our section up to here. Now the observations, I like to record what's relevant to the patient's age and chronic conditions. So most of our adult patients, we're going to be doing things like height, weight, BMI, waist, blood pressure and heart rate. If it's a health assessment, as an example, we're probably most likely doing things like a urinalysis, etc. If it was a patient with, asthma or COPD, depending on your equipment in that, 12 months, we're going to be looking at things like peak flow, oxygen sats, spiro, things like that. So it just comes down to, for me, the patient's age and chronic conditions, and also what equipment you have available in your clinic as well. So that's our observations in that part of the care plan prep. So that takes us all the way to there. The medication's a really big section. As I said, I prefer to generate the paperwork for the home medicine review if the patient's actually eligible for this. In my prep before I call the patient into the room, so that 10 minutes that I take before I call them in from the waiting room, it's more me just having a quick look at the medication they're on. So as an example for this patient where I've said that they've got asthma, if I couldn't see an inhaler, I'd just put like a little question for myself to ask them when they come in the room. If they're using an inhaler, or if they do they have they got a spacer as well? So I like to ask about any particular medical equipment. So if it's our diabetic, are they using glucometers, etc.? Like what equipment are they actually using? A lot of patients have never cleaned their spacer. Some have still got the original one. And other patients with things like CPAP machines and stuff. So it's really important to ask about that equipment maintenance. If you're not sure about what to ask, I've got a couple of sample questions there that you can look at. So we're obviously, when the patient's in the room, we're going to be talking to them about some of these other things. So, they're taking any medications that aren't on the list. Are they taking anything over the counter? Do they think they're having side effects from anything, etc.? And then the issues around, dispensing and things can also be problematic for some patients as well. And then anything to do with the equipment and maintenance, I think, is really important. So if they've flagged something, it's more about me flagging that so the GP can action. So if they've said that they no longer take a medication, as an example, it'd be something that I kind of documented. So if it was something that they needed a home medicine review, I would actually document that in this section. So I'm just going to bring up the home medicine review chapter just so we can have a look at that. So for those that haven't done one of these before, they're a really beneficial activity for the patient. Depending on your area and your availability of accredited community like pharmacists, it's an activity that might take anywhere from a couple of weeks, with the turnaround from when you do the referral anywhere up to 6 to 8 weeks. So the reason I prefer to do the home medicine review referral when we do the care plan is because we're most likely seeing the patient for that 3-month review for these patients that we're doing the home medicine review for. And so we usually have that report back by the time we see them for the review. And the 900 item number can't be billed till you see the patient with that report and send that notations and other information. For those that have done that, comes back usually in a table format with the recommendations from the pharmacist, and the GP will write their actions next to it, and then we send it back to the pharmacy. So it can't actually be billed until all of those steps have been completed. So my preference is to do it, the referral at that time, so then we can actually bill it when they come back for that review appointment. So that 900 can be billed on its own with a consult, with a health assessment, with a care plan, with a review. So it's a little bit of a unicorn item number. There's lots of different reasons that we can do a home medicine for. The most common for some of our more complex patients is that they're on lots and lots of medications. So they don't have to have all of these reasons, but obviously it might be something like, they've had a recent discharge, or they're, seeing multiple specialists, and you might think that there's something going on, side effects, things like that, or they might not be, managing their medications well, etc., or they've had lots of changes to their treatment. So this is a really beneficial activity. We'll walk through the steps a little bit later. Like once I finish the care plan demo, I'm going to jump back into this. But just so you can see why we would actually do that referral in this care plan appointment. So if that was me and I flagged that they could actually be eligible for a home medicine review, when I have the patient in the room, we'd be discussing that. So I'd explain what it is, and then I just put needs HMR, and it might be 5+ meds, patient consents, and then all I need to know is the name of the pharmacy, is how I'd normally just do it. So if it was, Terry White as an example, we'd pop it there. And I will generate that referral after the patient's left the room. So for me to generate that, I just need to know that information. And I'll show you that referral at the end and how quick it is to generate. So you'll actually have the template of ours that you can import into the system, and it takes about 30 seconds to generate that referral. So it's just really quick to kind of add on to this activity. The bloods and pretty much everything else after this section is a little bit of Groundhog Day or repeat, because every time we see the patient, we're going to be saying the same thing. So when was your last set of bloods? When's the next set of bloods? So depending on the patient's chronic conditions or medications that they might be on, will determine the frequency. So it's usually the GP deciding that, but usually it's something we discuss at that clinic level as well. So it might be, our patients with diabetes, we're doing the bloods, every 3 months as an example. So I usually have a quick look at the bloods. I normally just document it like this. So if it was last bloods, let me pick a date, 12th of November. Some people will write some extra information like what the HbA1c or cholesterol, etc. was. But basically what I'm trying to do, putting this information together, is figure out when this is due next. Because remember, this is our care plan that we're putting together with the patient. This is our big to-do list, and we need to help the patient figure out what needs to be prioritized between now and that 12 months. So what does that 12-month to-do list look like? And then we have to look at that big list of things that need to be completed, and pick a couple of those tasks to do between now and that next review appointment. Okay, so I prefer to, especially when you've got patients that have got, lots of complex conditions and activities that need to be completed, I prefer to look at it in a 12-month snapshot and then what's due in which month. So as an example, if we're doing 3 month bloods and this was done, 12th of November, that's December, January, February. So I'm just going to put here due February. And as I go down this list, you'll see that we end up with lots of different little due dates, and then we can help the patient break those up into smaller, achievable tasks to get completed between now and that next appointment. The next little section's the most important for me, because this is going to help us decide whether we've got enough for just the GP management plan, which means it's just the GP, the nurse and the patient usually, or if they've got multiple team members and we're doing a team care arrangement. Now, obviously, this is something that's going to change in July next year, but obviously I still want to know what this information is. So as I said, the process will most likely remain the same, but probably a little bit less paperwork in putting together that team care arrangement. So the specialists in allied health.
Sorry, Jane, can I interrupt you for one
Yeah,
second? We have a
yeah,
relevant question just before we move on.
yeah, sure.
We have Lisa, and she's saying, I'm curious to know how others are recording vaping, especially vapes containing nicotine. Also, how others might record marijuana smoking, as the risks are different and do not fit neatly in the pre-made smoking
I
assessment.
know. I know. There's the reason I bring it up as the topic is because every single clinic does this differently. So a lot of clinics will do the smoking, vaping, marijuana, usually in that little smoking comment section. Um, I think it's something that really needs to be adapted a little bit more, just because of the other drugs and substance use that's quite relevant in today's society. So I do recommend just jumping into that ADF um, health assessment, because this is the only little drug and alcohol assessment that's sitting there. So they've got a little section there on substance use. So I'm not saying to do the ADF assessment, but you might want to take these questions and add it into your text shortcut as an example. Um, or just create your own text shortcut. But you can see it goes through, in the past year, how often have you used like illicit drugs? So you could actually make that into quite an easy little text shortcut. What drugs? So you can see they've got like a list. The use of alcohol or drugs cause any problems in your life, etc. So for me, this is the only section in that software that actually has that substance use. So it's missing from pretty much every software. We've had to do like a little workaround in each of them. So documenting it isn't easy, but whether it's something you feel you can actually add in there, it's just hard for everyone to see it. Some people will put it in that social section up there, but I guess for me, I want to be mindful. Some people will put it in the past history and add it in there. But you've got to be mindful that when we're printing, referrals, things like that, some of this information is going to be visible and things like that. So it is a clinical conversation to have as a team, just to be comfortable knowing where everyone's actually recording this information. It's definitely relevant, but there's no specific spot for it, unfortunately, at the moment. There is talk like of the updates kind of coming around it, but I haven't seen anything come through yet.
Thank you so much, Jane.
Yeah,
Apologies for interrupting.
that's okay. It's 100% relevant. It's really important to record. It's just figuring out where everyone's happy to record it in your team until they sort out the software bit in the background. So yeah, if you don't have much time before you need to call the patient into the room, I prefer to do this specialist allied health section because this is the bit where I have to kind of look through the documentation. Obviously, if it's the GP doing the plan, they usually know exactly what's happening with the patient, and because obviously they've done the referrals, they've, actioned the, after visits. But myself, if I've never met this patient before and I'm putting their plan together, it takes me, a couple of minutes to kind of read through that documentation. So I've got example formats of how I like to lay the information out. You don't have to do it exactly like that. I do it in like a bit of a one sentence handover. So I'm going to cheat tonight and just copy paste mine in, and then I'll walk you through what that looks like in a sec. But basically, I lay it out in that way so it makes it easier for me to see what's missing and where we're up to. And then if someone else might be missing from that team. So as an example, you can see my patient's got diabetes. So the people that I'd expect to see in the last 12 months might be, as an example, an optometrist. So if I go through that documentation and I can't see anything from the optometrist, then I'm just going to put my question mark because that's going to make me flag that to the patient when they come through. So I'd be like, oh, I saw your other, reports from the cardiologist, etc., but I couldn't see anything. When was the last time you had your eyes checked? So it just means that I can see where the gaps are quite quickly. So the way I lay that out, you can see I've just put cardiologist, the last date they were seen, and the name of that provider. So I'll just put an example here. So last seen 24th of the 10th, 24. What happened in that appointment and when they want to see them again. Now, the reason I do it like that is because I want to actually check with the patient that this actually happened. Because what the patient hears sometimes is not exactly what happened in that appointment. And I usually use my dad as the prime example for that. So he's hard of hearing. The last time we actually went to the cardiologist, they changed his tablets and, he was kind of sitting there nodding and smiling. And but with everyone wearing masks and he relies a lot on lip reading now, he didn't hear much at all and didn't ask till we kind of got out of that appointment. So he's like, what did they say? And I'm like, oh, they wanted to change the tablets. But, it's something that we just need to double check because if they haven't actioned it or they haven't, had a test or, something done, we might need to chase something in the background. So yeah, I just like to confirm that they've actually made that change or had that test completed or done that particular follow-up. And then if they've actually got that review appointment booked. So if this was in October, then this one is due in April. So I just kind of lay it out like that. The specialists were usually the first people to start that next appointment process. So a lot of patients already have those appointments booked 6, 12 months ahead of time already. But if it was something that was overdue or that appointment had been missed, it might be something that I need to help follow up with the patient. So this section does take a little bit of time to complete, and it's usually the bit that the patients, especially with multiple conditions, need a little bit of a hand with. And so sometimes I might, if they're overdue for that appointment or we're chasing a report or they're not sure when the last check was, we'll actually be ringing while they're in there. And so I'll be like, oh, I've got Stuart with me. He's not quite sure when his last eye check was. We'll find all that out. If he's actually due to be booked back in, I'll actually hand the phone over to the patient and they can book that time. And it's the same reason that we spoke about last week around the patient engagement. If the patient actually books that date, the time themselves, they're more likely to attend that appointment. But I find that the challenge is them picking up the phone. It's not actually being able to say what day and time suits them. So yeah, this little section does take a little bit of time to kind of get that information together. Now, the medical history we didn't kind of touch on yet, but when we get to this next bit around the prevention and early detection, I'm going to jump into the past history with you and have a quick look as well. Now, this prevention and early detection section and some of these things, some people prefer to just do straight into the documentation in the care plan, and that's okay. You can feel free to do that. I prefer to lay it out here, and it's more because some people won't go back into the care plan and have a look. They're more likely to click back into the last couple lots of progress notes. So they're more likely to see something that catches their eye or needs to be actioned in this section sometimes. So I do prefer to lay it out in here, but it doesn't mean you have to do it exactly how I'm doing it. You might just do, a certain section, and then the prevention, early detection you're putting together in the actual care plan document. So it's your own preference in those little sections. But for me, this one is those other activities that may need to be completed because of the patient's age or other chronic conditions that they may have. So there's other activities that we need to complete. They're overlapping usually because of so our patient with asthma and diabetes, they're going to need immunisation. So immunisations, cancer screening, lifestyle modifications, they're the three overlapping. And then depending on what other conditions or risk factors they may have, we may need to do some of these other activities as well during that next 12 months. So where our specialists in allied health will like a bit of a one sentence, I like to do mine more like a little grocery list. So if this was me, I would have this expanded so it sits like that all the time in my text shortcut. So I'm not writing this every single time, but I usually just break mine into these four little sections. So immunizations, cancer screening, lifestyle, and then everything else for me will sit in that other section. So immunizations, if they're not due an immunization between now and the next 12 months, I don't record it here. So, but if it's something like, Pneumovax due May, cancer screening, it might be, skin check overdue, lifestyle modifications. Now, this isn't to be confused with the patient goals. Lifestyle modifications mean things that we know the patient can change. So as an example, if it was something like they were a smoker, then I'm going to put, smoking cessation. If they needed to lose weight, we'd put like weight loss down there as an example. So this is the beginnings of the conversations. It's not necessarily the patient goals for those things to happen. So, but they're definitely on the kind of conversation of us putting that care plan together. Now, the other might be things like, an annual ECG for the clinics that are doing those. The patient has asthma, so we're going to be doing our, spirometry as well, and any of those other preventative and early detection activities that might need to happen in that 12 months. And some of those don't have a date. So I can just, tag that in with maybe, the next care plan review as an example. Okay, so you can see it just helps me figure out what's due between now and the next visit. So if we're doing the care plan today and our review is due in December, January, February, so 3 months' time, I can see very quickly what needs to happen already. So the patient's going to need bloods, and so I'll usually document this as I go. So if I know that information before I've called the patient in, then in my recommendations, this little section's the recommendations for the GP to review. So I normally just do this in a different color just to flag it down the bottom. But I'd put something like, needs path request, ready for that review appointment. It might be that they need a script or they need a referral, as an example. So just pop those in. You can see I've already got the next appointments out at reception. So I've got a book for GP/MP review in 3 months. I might decide to add the spirometry. If we say to the patient, I've got to get you back for your review in 3 months. You're also due your breathing test. How about if we get that done, while you're there? And so if that's the case, I'll just tag that to reception. So when they book that next appointment, they can actually allocate a little bit more time. So I can do that as part of that. And then you can see they're overdue for the skin check. So I'm going to put that as well. So book for skin check. So these two are kind of our, next actions between now and that next appointment. So what the GP needs to review and action, and then what the patient will need to action on their way out to book those appointments in at reception. Now, this patient needs and goals and the patient actions, this is sometimes the hardest bit for us to do out of the whole care plan. So I know a lot of people struggle with this. I try to just picture it as a long-term experience though. So I don't want to push the patient too far in this visit and then not wanting to come back. And so I like to just see where they are in that readiness. So like when we ask questions around things like, smoking, how long have you smoked? So we do that whole, assessment part of it. And then are they thinking about quitting, et cetera. If they say no, there's no point us going those next steps and starting to, put a quick plan together and things like that because they're not ready. So I kind of think about the goals the same way. So I normally have a conversation and just say, this is your plan as well. So a lot of patients will use this and put together some of their own goals. I know like some of my nursing colleagues will give patients homework to take home and they're, coming back with a goal that they've, spent some time putting together. But I'll usually just give them some examples of what, other patients might have done. So, it might be that they're, trying to increase their fitness or, lose weight or quit smoking. Like as those kind of examples, I'll explain that they get the access to the allied health if they've got their team in place. And then I'll give some examples of what those team members might look like in the allied health. So I'll say, things like podiatrist and dietitian, etc. And is that something they're interested in looking at today? So don't be surprised, especially if this is the first care plan. A lot of patients aren't usually keen to go further than that in that first appointment. So sometimes I'll just put something like that we've discussed it. So it might be that we've discussed, health goals. And sometimes I just put something around, review next visit. So I might give them one of our little planning sheets to take home and they can put a goal and have a think about it ready for the next visit. The worst thing I can do is kind of push them that far and then they're kind of not coming back to us ever again, kind of thing. So it's going to be different from patient to patient. And some patients you will be able to have that, really good conversation, put some goals in place, and then, we're reviewing that when they come back. But it's not always like that. So don't feel bad if you've had that experience because it does happen and it is probably the most challenging bit of the plan. So the patient actions, so this is me just double checking those actions that need to happen between now and the next appointment. So I'll be saying things like, we need to get you booked back in for your skin check. I'm going to get you to do that on your way out, and you're going to need your bloods done before you come back in for that review appointment. And it's just so they're clear of what those next actions are as well. If it was something that we'd actually put a goal together, so say the goal was, weight loss as an example, we'd set that goal, then we'd put what those actions were towards that as well. So that would all go in that little section. As I said, some people will put everything from here down just straight into the plan. It just depends how you want to see that information. So I hope that makes a little bit of sense. So once I've done my prep bit, which is everything I can fill out before the patient comes in the room. So that's me going through putting in things like the conditions, etc. I'm just going to go into this prevention early detection bit to show you in the past history, just so we can talk about that quickly, because I think that's another great conversation for the clinical team as well. Prep before we call the patient in from the waiting room, that 15 minutes or so where we're really engaged with the patient and filling in the blanks, talking about what goals we're going to put in place over that next 12 months and just reviewing. So if it is the review appointment, we're going to be seeing where they're tracking against those goals and reviewing and adjusting where we need to. And then that last bit is me usually doing the paperwork bit because I don't want to engage the patient in that, 15, 20 minutes. And then I need to type like crazy to kind of get everything finished. So I'm not usually one person that can do both at the same time. And they're kind of sitting there, just watching me type and very bored. So I prefer to just kind of end it with a high engagement and like, I'm just going to finish typing up your paperwork. Dr. Smith's got one more patient in front of you. If you just want to have a seat back out in the waiting room, I'm going to get you to book those appointments on the way out. And so that just keeps it really high engagement and less painful than them kind of sitting there for that 45 minutes altogether. So let's just have a quick look in this past history section. So not all clinics do it, but that prevention early detection information, sometimes it's a bit to look up in the different documentation sections and investigation reports where they come in. So I actually prefer to add things like, mammograms, the colonoscopies, even the skin checks. I like to add onto that past history section. So it just makes it a bit easier. If we print out that past history list or summary for the patient, then they've got all that information in the one spot as well. So it just makes it easier, especially with the comment section. The comment section is not so easy in Medical Director to read that with the past history, but it allows us to actually put the information. So you can see with with the mammogram one as an example that I put, the date, next screening 2 years as an example. So, if it's a surgery, I'll usually put the date, the exact date if we've got it, otherwise an approximate year if we don't have the exact discharge, and then the doctor in the hospital that was completed at. So yeah, prevention and early detection side is really important if you can decide as a team if you're, number one, happy for the nurses to update the past history when they're doing that part of the documentation, because obviously we want that information to be up to date before we generate the paperwork. And then number two, are you happy for the prevention, early detection information like skin checks, etc., to go on that past history as well? So let me just generate that document. So some clinics are using this care plan section. When I go to add that care plan, if it's the first one, I usually generate it from scratch. I don't continue on with the same one that we've had. It just allows me to kind of look at it with a new set of eyes. Now, because you'll have access to the online resources, you'll have access where it says this little template section. These are actually called disease templates. So there's instructions on how you can import our disease templates, which means less typing. So when you click on here, template, you can see we've added our own ones in there. So as an example, you can just kind of double click and all of that information will come through. We've also added in the prevention and early detection side. So if I just double clicked on that, I can delete what's not needed. And then you'll actually set up your providers in the background for those regular ones. So it just makes it really easy to see all of that information, because I don't want to set up the templates, these disease ones, with like immunization as an example for cardiovascular diabetes and asthma. It's going to be repeated like 3 times. So we have the basic information in each of those chronic conditions, and then we have the overlapping information that you saw in that prevention and early detection table in a separate disease template. Okay, so depending on your clinic, you may be printing out the paperwork or just generating the document into draft, and then the GP will review and print that off when they see the patient. So I'm just going to click out of here to close. Actually, I'll just hit save so you can see. So we've adjusted our system template in the background. I like to see additional information like the past history, family social history, and the last set of investigations. Not every clinic wants to do that. So it just depends on what you want that document to look like in the end. So there is a system template that you can import. Anything under this section is a system template. And then we've also got our home medicine review template that you can import as well. There's some clinics that still use the care plan document up in a word processor. And if that's your preference, you can do that as well. So I'm just going to show you quickly the home medicine review referral so you can see how quick that is to generate. So it's just new letter. The template will populate. You'll select the pharmacy or pharmacist, the medication, past history. And then the pharmacists obviously want to see the trends. So for patients on blood pressure medication, they want to see the readings for the last couple of months, weights, etc. So you can see the date range will automatically give us a 12-month date range. But if you just click on the today's date and then click again and just arrow back a couple of months, just so they have a couple of months of reading. So I don't untick anything. I just change the date range. Insert the most recent and relevant investigations that they would be interested in from that pharmacist level. And then we've got custom fields. So you can see I haven't typed anything yet. I'm just ticking those relevant bits that we need to. We've got our pre-selected criteria down the bottom as well, and then just insert. And that's it, print and save. Okay, so that's a really quick add-on referral that we can do as part of that activity, and most likely you will have back ready for that review appointment. I know we're very close to the time, so I'm going to end there if everyone's happy with that information. You've got a couple of extra slides in that slide deck of, different observations and things to record as well. But if there's any questions,
We do have some questions. If
yeah,
we
that's
can
fine.
go over them, that would be amazing.
Yeah, I'm just going to click over to the screen with the toolkit information. Do you want me to jump in the chat and have a look?
Yeah, yeah.
So yeah, the online portal, you'll have access to the text shortcuts and templates in there. Let me just jump into the chat.
Would you like me to read them?
Yeah. Oh, I haven't clicked on the right one. Yeah, you can read them if you want, Julie. I can only see the...
So the first one is it enough for auditing purposes to perform care plans in best practice in the care plan template offered? Usually this information is not pointed in the care plan template.
Yeah. That's why I prefer for the template to be edited in best practice. For those that haven't done it before, there's step-by-step instructions in the online portal in our little template section. Just be aware that you can actually change anything. So these are all the system templates. So the care plans, health assessments, anything under that enhanced primary care is actually a system template. Just keep in mind any changes you make in that section will affect everyone. So it's kind of like a global section. So I prefer to adjust it just because I don't think the template has enough information. And a lot of clinics will just say to me, Jane, I don't like that template. And they just said that in that little section, customize system templates, you'll be able to see the plan that's there. So I'm going to show you the one. Yeah, you'll be able to see like ours and be able to import it. It's just whether you've got the permissions to do so. But all the instructions and the templates are there that you'll have access to that you can actually pull them in. So yes, I would change it is my 5 cents worth.
We have some other questions. If we don't get to your question, I've taken note of all of them and we can answer them via email. We're going to be sending all the resources and recording via email in a couple of weeks. So there is one question that says, could you show us what your goal planning sheet that keep patients looks like?
Oh, the goal sheet.
Yeah.
I don't think it's in the online portal, but I'll pop it in. I'll get the guys to pop it in there for you.
Ah, thank you. And I think in interest of time, I have taken note of the questions. I will type them and send the answer via email along with all the other resources. Is that okay? For everyone who attended the session, thank you for attending. Remember that at the PHN, we have a wonderful team of engagement officers. Reach out to them, reach out to us in practice support, and we will be happy to help. Thank you, Jane, for the session.
Okay.
And see you next time, everyone. Thank you.
Thank you.